Okay, hello everybody. Thank you for being here for the session, deciding which is the best technique on the treatment, non-pharmacological treatment of hypothalamic hamartoma seizure. And we are looking if there is a best technique or not. And we know that the surgery for the hypothalamic hamartoma changed a lot in the last 25 years. We move from microsurgical approaches with pteronial resection, transcallosal, transfornical resection based on the anatomical features of the hamartoma, but this surgery presented with a lot of severe complications, at least in 1/3 of the patients, 1/4 and 1/3. And we are lucky that many other minimally invasive approaches popped in the last 20 years with very interesting results, either from the point of view of complications and affect the outcome on seizures. So today we try to give a landscape of not all the techniques, but I would say the main technique that are used for treat these patients. And we start with Konstantin Tuleaska. Konstantin is a neurosurgeon and radiosurgeon, I would say, in Lausanne. He has a huge experience in the radiosurgery for epilepsy and also other type of neurosurgical field like oncology. And he has a PhD based on radiosurgery mainly, and he got many scientific prizes, in particular in France, for his production. And we are very keen to have you here and to hear about which is the role now in 2024 of radiosurgery for these patients.
Hi, good afternoon. Thank you, Michele, for your kind introduction, and I want to thank you for having me today because you invited me. So I would share with you some of the thoughts I have on the role of radiosurgery for hypothalamic hamartomas. What are the best treatment indications in this for this technique, and what are the results on the long-term basis? Now, just a couple of introductory slides for those of you who are not familiar with radiosurgery. Mainly radiosurgery allows to deliver a high dose within a small to medium-sized target with a low dose outside the target in a single session. And in particularly in epilepsy, it can have both a lesional and non-lesional effect. The lesional effect had been demonstrated in rat studies, and you have one of the illustrations here. But there are also described as non-lesional effects, for example, in an arteriovenous malformation of the central cortex area, where you have seizure arrest before even the AVM will obliterate. Now, for hypothalamic hamartomas, radiosurgery is one of the indications. Of course, you know there are other types of epilepsy which benefit in selected cases, in my view, from radiosurgery, like the MTLU. Extratemporal partial epilepsy in extremely selected cases, but also corpus callosotomy, who had been upraised the last years, I would say, mainly. Now, I think, and I will show you a meta-analysis done by Michele Rizzi, where we can have different results in the literature, and I think this is clearly explained by a couple of things. One of them is that we don't see the same target. If you take two different persons, two different neurosurgeons or radiation oncologists, will see certainly not the same thing. And I think this will account for the variability of the results. Of course, it is an image-guided technique, so you need to do multiple MR sequences to have a better targeting. Otherwise, in these lesions, which are extremely challenging, if you do only a T2 weighted standard MR for a lesion which resembles much to the normal brain, you will miss a certain part of the target. Another problem, and that explains the complications we have in the literature for this technique, is that you have organs at risk. You have the optic pathways as the most important for sure, but you have also the mammillary bodies, you have the fornices, and so forth. And I think one of my favorite phrases is that effectiveness is defined by radiobiology, not by humans. So you need to understand what you are treating. You cannot treat a hypothalamic hamartoma as you would treat an arteriovenous malformation or a brain metastasis. That's a typical plan for a single fraction radiosurgery. You have the optic apparatus, which is the most sensitive structure to radiation. There are different cutoffs for the radiation dose the optic apparatus can receive. I won't get into it, but you need to protect it actively, and you need to understand what you are treating exactly. One of the issues, and I will insist on this, is that if you irradiate larger volumes, you will have more complications and less effectiveness. And I think one of our colleagues, or several of our colleagues, are pushing a little bit the limits of radiosurgery, and they are trying larger volumes which are not suitable for radiosurgery. And this will explain what we have as variability in terms of results. And that's an example from an Indian paper, which I personally don't recommend, but to have it as an illustration, if you treat higher volumes, you need to hypofractionate. I think there is limited data for hypothalamic hamartoma on this topic. I wouldn't do it, but just to have an example. Now, in terms of effects, and I will pass a little bit through neuropathology, clinical, and radiological. You will have decreased cell densities. That's a paper from the Kerrigan's group, extremely active on this pathology, where you can see on the right side of the screen typically a decreased cell density, but also a vascular effect, which is quite classic with radiosurgery, and abnormal capillary structure and the thickened endothelium. Now, in terms of clinical outcomes, I would pass a little bit through the most relevant trials, I would say. One of them is the Marseille prospective trial, 48 cases. An important and key factor for outcome is the prescribed dose. In this trial, the median dose was 17 grays. That's, in my view, a key factor for a good outcome. And you can see also an important information of this paper that several patients, almost 60%, got a second radiosurgery, and I will get back to the indication of the radiosurgery in the discussion part. So that's quite an important number. In terms of angle class 1, it's around 40% in the Marseille data, which is the most optimistic data, I would say, in the current literature. And if you take angle class 1 and 2, it's around 70%. You can see here that also salvage microsurgery had been done in 16% of the cases, 8 out of 48. An important information to give to the patients, in my view, is that there is a delayed clinical effect of radiosurgery. So this is following a time frame which is quite specific, extremely different from the other techniques. And it's usually taking months to years to have it. And you have an example as per type of seizure. If you have a gelastic, focal dyscognitive, or tonic, or secondary generalized, you won't have the same time frame for a clinical improvement. And I think that's an information which is important to share with the families to know exactly what to expect and when. In terms of complication, I think also an important information is that almost 20% of the patients will have a transient increase in seizures. And this is, again, important to underline. That's normal. One patient out of 5, it will have it. I think that's a fair information which is uniform in all the trials performed with radiosurgery, and it's important to underline. Transient poikilothermia, it's also one of the complications. It's roughly 5 to 6%, depending on the papers. It's 6% in the Marseille data. In terms of heteroaggression and hyperactivity, more than 50% of the patient cured in terms of heteroaggression, and hyperactivity around 45% again in the Marseille data. And in terms of cognition, another important paper done by the Regis group, which follows other papers. Mainly there is no decline and major improvement in roughly 30%. Now, if you take the different types of tests, you range between 20 to 46%, 46 for the working memory index mainly. Endocrine functions, that's a paper from the endocrinologist in Marseille suggesting that there was no difference, statistically significant difference in terms of body mass index before and after radiosurgery, and only one patient having a TSH deficiency after treatment, so an extremely low complication endocrine profile. That's a recent multi-centric trial which grouped patients from the US, Europe, and India, so quite a lot of heterogeneity inside this trial, but it just appeared in neurosurgery this year. Mainly you can see the median volumes were less than 1 cc, and I think that's good. I think, again, radiosurgery is fitted for small to medium-sized targets, so we should avoid larger volumes. Marginal dose around 16 grays, and you can see also vast majority of patients treated in one fraction, so single fraction stereotactic radiosurgery. In terms of outcome, data a little bit less optimistic than the Marseille trial, 55% angle class 1 and 2, which I think it's extremely realistic in patients with minimum 3 years of follow-up. It's what I got in my experience, and I think this is a fair number. And I think an important and key aspect is that on the radiology side, before 3 years, you won't have any changes. It's not like a benign tumor, vestibular schwannoma, for example, where you'll find quite important range of changes, even at 1-2 years. So to see something, you will wait for 6 years, and this does not necessarily correlate with the clinical outcome. I think this trial also highlights the transient increase in seizures, 20%. It was 16 in the Marseille data, so this is quite similar. New onset of hormonal deficiency in 5% of the cases, and poikilothermia in 2%. I think the numbers are quite similar to the Marseille data, which is the largest for the moment. You can see also that 23% of the patients got an adjuvant treatment because of poor seizure control. With this, I will quote 2 systematic reviews. One comes from our chair, Michele Luisi, which is a balanced systematic review. We were just discussing that just before the session. Mainly, this paper highlights the fact that for the seizure-free cases, radiosurgery is doing less better than microsurgery, and endoscopy less than radiofrequency thermocoagulation. Of course, this is with the price of the permanent hypothalamic dysfunction, which is higher for microsurgery and lower for endoscopy as compared to radiofrequency and the LIT. And the incidence of permanent neurological disorders, that's not new, is higher for microsurgery. Michele was also evoking this at the beginning of the session. And significantly lower, of course, for radiosurgery, which is more minimally invasive. So radiosurgery has a safety profile with less efficiency as compared to the standard techniques by a different mechanism of action. That's another systematic review, but it's not a meta-analysis, just regrouping the relevant papers in the literature. I think one of the key aspects from this paper was that you can find improvements in behavior and sleep patterns. You can have also a positive effect on behavior, which tends to occur very early, and that the adverse radiation events are actually rare with this indication. I approached the discussion with a couple of positive predictors for angle class 1 and 2. Again, I think it's important to underline that we need to treat small to medium-sized targets by radiosurgery. Higher grades volumes are not an indication. We need to apply a marginal dose, which is at least 17 grays in my view. We did a nice paper 2 years back suggesting that if you do a voxel-based morphometry analysis with just a T1 weighted image, if you would have higher pretherapeutic gray matter density in the mesencephalum tegmentum, you will get more clinical alleviation, and this was extremely statistically significant. And I think we need to do earlier treatments, and that's one of the key factors also pumping up in the recent literature. Another thing which we are exploring also is the treatment time for reasons I won't enter here, which are related mainly to radiobiology. The shorter the treatment time, the better the improvement after radiosurgery. We are still exploring the data, but this goes again to small to medium-sized volumes also, so shorter treatment times are certainly better for the patients. Now, it's important again to underline to the families the time course of events which are related to a delayed efficacy, inconstant immediate improvement, which is not necessarily a problem, dramatic sudden worsening of the seizures, which are up to 20% once again, sudden seizure cessation and sometimes distinct delay as per seizure type. I was showing you this just at the beginning of the presentation. And of course, this depends on what you had treated. Did you treat the whole lesion or not? Do you have other gray matter heterotopias outside the lesion, which you were supposed to know before, widespread of the epileptic zone, and etc. And the question is whether you can use radiosurgery and combine with other techniques. The answer is certainly yes. That's a case we treated in Marseille. You can see a large volume target before microsurgery, decreased after. There's the image in the middle, and the radiosurgery with a good outcome. And the question whether you could do stage treatment, like 2 radiosurgery treatments, I think it's safe and effective. But I think there is a time frame for that, and you should wait at least 2 years between the treatments to see whether the first one got effective and whether or not you had complications in a particular patient. With this, I approach the conclusions because I promised Michele I'll speak 15 minutes, so I'm approaching my 15 minutes. I think radiosurgery has certainly an excellent safety and efficacy and complication profile. I think 40% angle class 1 is realistic. I think the angle class 1 and 2, it's around 55 in my view, at least. I think we need to do it again for small to medium size hypothalamic hamartomas, so we really need to have the best patients for the indication. I think also that the minimum marginal dose would be around 17 grays and not less. Of course, we need to pay attention to the optic pathways. We need to do early interventions, and we can use radiosurgery in combinations with other modalities, including surgical approaches. And one of the questions that might rise is that the risk of carcinogenesis is low, at least with the current data we have in the literature. Thank you.
So we have space for a couple of questions, since we have time. Mr. Dofer.
Hi, Christian Dorfer from Vienna. I have a question regarding target volume selection. As you said, volume matters in terms of morbidity. So for all the other techniques that we will hear in a minute, disconnection is the aim of the procedure. Is it an option also for radiosurgery not to, target the whole volume of the hypothalamic hamartoma, but just the interface between the hypothalamic hamartoma and the hypothalamus itself? Is it an option, or is it just a stupid idea?
So your question is whether we should target the whole volume of the hypothalamic hamartoma or not?
Yes, or if it's enough just to disconnect the hamartoma, not to radiate the whole volume of the hamartoma. Just the interface between the hamartoma and the brain.
I think we should treat the whole volume. That's my personal view after 14 years of radiosurgery.
Okay, and has it ever been tried?
Yeah, some authors did it and the results are not terrible. Reason for what, they are not published. But I cannot tell the teams, but I know what they did. We discuss quite frequently, and that's not an option. That is why it hasn't been published.
Thanks.
Please.
I have one question. From the family point of view, the possibility of having an increased number of seizures and a delayed effect in seizure reduction may be something important. My question is, do you see other problems like worsened behavior for some time, or only the increase in seizure number?
That's a good question. Yeah, it's only an increase in the seizure number. You don't have any other problems, but that's already quite an important problem.
In your experience, what was the lowest age in children that you have treated, just because of the frame that needs to be fixated? What's the lowest age you have done?
So the question was, what are the
lowest age of the children?
The second stage dose? No.
The age of the
lowest age. I think it was 3 years old, if I remember well.
Okay. Okay, thanks.
Okay, thank you.
Thank you.
So, there is one
Just the
more
last
there.
question, sorry.
Sorry.
I'm back.
You mentioned the behavioral issues that these children often have. This is probably something I would like to know of everyone who works with these patients, because these problems are often more serious for the child and for the parents than the epilepsy actually is. Could you maybe tell a little bit about your experience of the effect of stereotactic radiosurgery on the children's behavior? It can be anecdotal, but I would like to have some information on that.
Yeah, you're speaking mainly about heteroaggressivity and the psychiatric related abnormalities. Yeah, usually I think a fair data is about 50% improvement in these cases. That after reading and all the literature and doing myself this, I think half of the patients will improve on these conditions.
Thank you.
Thank you.
Just about aggressivity, you just have to keep in mind that the surgery for aggressiveness, refractory aggressiveness, is done in the retrohypothalamic region, so the region which is posterior to mammillary body. So it would be very nice to investigate in those cases on which there is an improvement of the aggressiveness if the dose was delivered only to the classical anterior part of the hypothalamic region where the hamartoma dwells, or also the posterior connection are interested, because we know that this is generally the area which is effectively targeted in a very rare population of patients.
So we are going to have our second speaker, Dr. Santiago Candela. Santiago Candela is responsible for the pediatric part of the functional epilepsy surgery unit in Barcelona. We are colleagues, and he's going to speak to us about radiothermal coagulation and laser for the treatment of hypothalamic hamartomas. They started very early to use the technique in the pediatric population with hypothalamic hamartomas, and that has allowed them to have a very important series he's going to talk to us about. Thank you.
Thank you, Mar. Good afternoon. Yes, I will talk about these two supposed to be minimally invasive techniques. We don't have experience on radiofrequency for hypothalamic hamartomas, so I will expose a bibliographic review, and afterwards I will talk about our own experience on laser ablation for this indication. So you all know what hypothalamic hamartomas are and that they are epileptogenic, so I will skip this slide. And we will start with radiofrequency thermocoagulation. This technique was first published in 1997 by Kutniecki in Alabama, just one case. And in 2016, there is the first series in Japan of 100 patients. So this technique consists in inserting a radiofrequency probe guided by stereotaxy, and it allows to perform multiple spherical lesions of more or less 5 millimeters in diameter, hitting the tip of this probe, okay, 74 degrees for 60 seconds after a trial time. At the beginning, as all the techniques used for this indication, it was advocated for treating just small and medium-sized lesions. But after the first cases, the same authors advocated to extend the indication for larger, for type 4 hypothalamic hamartomas. And it's very useful because in case of recurrence or persistence of seizures, surgery can be redone without very, very easy. The outcome, it has resulted more effective and safer than open surgery, of course, and also more effective than other previous techniques. Kameyama, in the series of 100 patients, reported an efficacy for gelastic seizures of 86% of seizure freedom and 71 for all seizure types after 3 years of follow-up. And for hypothalamic hamartomas, it was also very effective with 81% of seizure freedom of gelastic seizures and 62 from all types of seizures. Complications. Well, that's the reason I said it was supposed to be minimally invasive, because there are complications, yes. Of course, radiosurgery is safer because we have fever, disturbance of consciousness, transit worsening of seizures, all this transit, but also there are precocious puberty, weight gain, pituitary dysfunction, Harner syndrome, etc. There are complications in more or less 1/3 of the cases, as it has been published. So now we switch to the technique we know, that is the laser ablation technique guided by MRI. We use the Visualize system provided by Medtronic. This is a real-time control by MRI ablation system. We insert also a probe, a laser probe, that is cooled by a cooling catheter that is just 1.6 millimeters in diameter, and it is connected to a laser source of infrared. That what does is cools a therapeutic window. There are 2 types that are approved to use in the brain, of 3 and 10 millimeters. For hypothalamic hamartomas, the most useful is the 3 millimeters one, because the lesion is more controlled, but we have also used the 10 millimeters one for larger lesions. I will show you. So the European Medicine Agency approved this technique in 2018, and we start with the simulation that you are looking at in the video in 2019 with the LEAD program. Since then, we have performed 66 procedures, 30 for hypothalamic hamartomas in 22 patients. The youngest one was 15 months old when we did the operation. Sorry. So, in this picture, you can see our operating room facility. We have a room-to-room MRI device just at the other side of this door. And well, the system is very safe because it allows us to mark some points, high temperature and low temperature points, that stop automatically when temperature reaches the predefined temperature. So the high temperature points are used to know what's the temperature at the target where the ablation is being performed, and the low temperature markers are used to protect surrounding structures like the optic tract, mammillary bodies, the contralateral hypothalamus, etc. So at the beginning, the first series that were published, they advocated just to disconnect the hamartoma, like with endoscopy. But when we started, we thought that as with small lesions, it was better to ablate all the lesion, following the neurosurgical principle of no brain, no seizure. So we started to ablate completely the hamartoma. In the previous image, you can see we have the real-time thermography image in the left, that is here, that you can see in blue. As the temperature rises, it changes in color. And in the right side, here, you can see an estimation of the lesion. So we can perform many lesions and withdraw partially the probe, so that complete the ablation of all the hamartoma. Apart from the real-time thermography, we can perform morphologic studies. It's very useful, the FLAIR or the T2 images centered in the lesion, to see how the ablation progresses. So in our hospital, we have performed 30 surgeries in 22 patients, including reinterventions, of course. All pediatric. The youngest one was 15 months old. All of them had gelastic seizures and some other types in some cases. And in most of them, we used one laser fiber. But in 9 cases, we used 2 laser fibers and 3 in one giant type 4 hypothalamic hamartoma. Here is the case in which we use 3. It has been performed a previous laser ablation and a previous open surgery in another hospital. And we decided to use 3 trajectories to cover better the remnants of this lesion. So the published outcome with this technique is 93% of seizure freedom in a series of 70 patients in the US by Daniel Carey. There is another series with 18 patients by Xu that also reports 93% of seizure freedom. And our initial series also reports a 93% of seizure freedom. Our present series has we have intervened more complicated, more complex, more bigger, and with more complex shapes hypothalamic hamartomas, and so our outcome is now 82%. But we have included really complex lesions. We have follow-up of maximum 5 years since the beginning. And we have experienced complications as with the radiofrequency thermocoagulation. There is 39% of incidence of complications like contralateral and strength deficits, unilateral Hundred syndrome that were reported in the series by Xu. And in our own experience, the most important, the most challenging complication or effect of the laser ablation is the postoperative edema. So we give patients steroids in high dose from the preoperative, but despite this, we have experienced fever, postoperative fever, and seizure worsening due to this postoperative edema. And we have also have severe complications as panhypopituitarism in 2 cases. You can see one of the cases of panhypopituitarism that the lesion was very, very close. This the third one down was very close to the adenohypophysis, or oculomotor third paresis in the first case here on the ablation of the trajectory at the beginning due to insufficient water cooling through the water through insufficient water flow. It happened just at the beginning. Now, the technique has become safer in our hands, but we have increased difficulty, including more complex lesions. Before concluding, just a few words on this technique, the magnetic resonance guided focus ultrasound. It's a technology that was approved in 2016 for thalamotomy for essential tremor. Now, indications of this technology are expanding, but it has been also tested for hypothalamic hamartomas. There are 1 adult and 4 pediatric cases reported to be effective, but as far as I know, there are more teams working with not so good results, and they haven't reported the results. So, to conclude, radiofrequency thermocoagulation and laser ablation guided by real-time MRI have superior efficacy compared to other modalities, and the effect is immediate. They have moderate safety profiles, yes. We have experienced some complications. They require inserting a probe, so they are minimally, but they are invasive, and they have bleeding risks of the trajectory of this probe. And the magnetic resonance guided focus ultrasound is an investigational option that potentially offers a safe, as there is no need to insert a probe, but I think that it needs to be worked a little bit more on this technique. So thank you.
Any questions for Dr. Candela from the audience? Yes? Just wait for the microphone.
Thank you for your presentation. I was just wondering, those patients who had radiofrequency ablations and then turned into MR-guided lead therapy, in your experience, what was like reasons or indications? Who underwent radiofrequency and then went to MR?
I think that the patients that can be offered radiofrequency or laser ablation are the same patients, the same indications. It depends on the disponibility of the equipment in your hospital. So we have the laser, we don't have radiofrequency. We offer laser ablation to all our patients. Maybe there is not difference in indication, but yes, there is a difference in the technique. Radiofrequency, all the publications advocate for disconnecting. And now, us, for laser, we advocate a complete ablation because the lesion that we can provoke with the ablation is larger than with radiofrequency. But the indications, I think, are the same.
No, but you said they were like reverting patients who had first radiofrequency and then needed to go.
Yes. Yes, they came from other centers, but
Okay.
if we had come to our hospital at the beginning, we have offered laser because that's what we have.
Okay.
Yes.
Thank you.
Thank you very much for this excellent presentation. My name is Ivanovic, I'm from Norway. We have started recently with this technique, so I have one question for you. How do you do and how do you feel with the protecting unilateral mammillary body? Is that so important or not?
That's the theory. In reality, it's very difficult to see the mammillary body, but when we see it, yes, if we see that it is not involved in the hamartoma, we try to protect it, yes. There need to be studies on the neurodevelopmental and behavior results. We are gathering all the information, but we didn't analyze. But yes, we try to protect it when it's not involved in the lesion, but it's not easy. It's not easy. The system we use, the Visual Ace, is going to improve next year in 2025. We are going to be able to fuse preoperative 3 Tesla images where the mammillary bodies will be easier to identify. Now with the background image that is just one plane, and it's very difficult, but when we see it, or at least we try to protect, yes. But we don't have analyzed the results, so I don't know if the behavioral and neurodevelopmental outcome is better when we did or we did not.
Just follow-up question, what is the psychological or cognitive profile of these patients that you have? Is that so important to pay attention for these?
Yes,
traits?
I agree with you. We are working in it. I don't have preliminary data yet.
Santi, which are the prognostic factors for reintervention? Is it lesion size? Because sometimes in the bigger ones, you from the beginning plan several fibers. So which are the patients who are more likely to be reoperated?
The type 4, of course, and with aberrant shapes. The ones that are more round, more fusiform, are easier to approach. The ones that have aberrant shapes with bilateral attachment have more probabilities to fail the first treatment.
And related to this temporary increase in number of seizures, is short-lived, of short duration, related to the edema and response to high-dose corticosteroids also?
In cases we have experienced this worsening, it was for 3-4 days maximum. Yes.
I think there is another question over there.
Yes, we also have very limited experience with these hypothalamic hamartomas and laser ablation. Is it also your experience that you see the heat dissipation quite nicely in the hamartoma and not in the surrounding tissue, as if the hamartoma is more conductive to the heat than the surrounding tissue?
Mm-hmm. Well, the laser is very respectful with surrounding tissue. You can also put these markers that protect the surrounding tissue, but of course, they hit. Yes. So if there is a cistern, it's safer, but we as complications, we have reported the asymptomatic mesencephalic edema that are the most frequent MRI findings in the intraoperative or immediate postoperative MRI. In 2 giant hamartomas, we experienced transient awareness problems due to hypothalamic lesion for contiguity also. So yes, tissue surrounding the hamartoma hits, and in large lesions that you deliver more energy, you can lesion the tissue and provoke complications. Yes, but theoretically, the tissues surrounding the hamartoma should be preserved, but in large cases it's difficult and they can lesion.
I just have the last question. You use usually transventricular route of placement of this laser catheter.
Yes.
So the question is, do you see any difficulties with this and the target point deviation you achieve with this one?
No, we usually use the transventricular trajectory, yes, because usually the shape of the hypothalamic hamartoma, its craniocaudal axis is very close to the midline. That's one reason. We use always the trajectory that is along the larger diameter of the hamartoma, that is usually parasagittal. That's first. Second, we avoid the primary motor cortex, because we had, at the beginning, we had these 2 cases of ablation of the trajectory to avoid an hemiparesia. So we try to plan this trajectory along the longest axis of the hamartoma, but avoiding the primary motor area, and if we can go intraventricular, we prefer. And we didn't experience any issue with the accuracy of the laser catheter is very stiff and it doesn't deviate with. No, especially in children that has a good brain, not brain atrophy. No, we didn't experience this.
Thank you.
Thank you.
A question about complication after MRI-guided laser interstitial treatment, because you did not mention the electrolyte disturbances and in particular hyponatremia. So I would ask if you had this type of complication in your series.
No, we have just 1 case of hyponatremia. It was the case that we had an hypothalamic lesion, a very large hypothalamic hamartoma. Just 1 case.
Thank you.
Okay, thank you
Thank
for
you.
the nice presentation. Let's move to the next speaker. Alessandro De Benedictis is a pediatric neurosurgeon involving in the functional neurosurgical sites mostly, and is working with Carlo Marras in Bambino Gesù Pediatric Hospital, and he has a great experience on epilepsy surgery, and also his research interest is on the brain connectivity. Thank you.
Thank you. Good afternoon to everyone. So this is my disclosure. So the first description of the endoscopic disconnection technique for the surgical treatment of hypothalamic hamartomas was reported by Delalande in 2003. So basically, 3 key factors enable the adoption of this approach. The first one is the fact that, as Michele mentioned at the beginning, while traditional microsurgical techniques provide not optimal epileptological results, they were also associated with a high incidence of postoperative complications, leading to the investigation of less invasive surgical solutions. The second aspect is that the hamartomas are malformations and not tumors. The third one is that the evidence that seizures related to hamartomas originate from intrinsic epileptic activity and not from the compressing effects of adjacent structures. And these factors support the concept that disconnecting the hamartoma from the surrounding hypothalamus rather than the complete mass removal is sufficient to prevent thalamic activation by interrupting seizure propagation through the mammillothalamic tract. So, similar to the shift from the hemispherectomy to hemispherotomy, it became evident that the disconnection of hamartomas yield a comparable seizure outcome, but with a less invasive approach and risk for complications. Additionally, Delalande proposed a new classification system, categorizing the hamartomas into 4 types based on their size and the relationship with the third ventricle. And this classification made the endoscopic approach more practical and applicable, facilitating the selection of the most appropriate surgical method among the available options. And for this reason, over time, different groups have reported growing experience with the endoscopic approach for hamartomas. However, to correctly evaluate results of the different studies, it is important to distinguish studies in which the hamartomas were treated by a poor disconnection from series in which the hamartomas were completely resected. And in my opinion, this is a quite critical and also controversial aspect. Also, with colleagues that reported the resection of the complete hamartoma. For example, Ritate indicated that a complete resection would lead to the best epilepsy outcome, while for other authors, resection will not be essential while associated with higher risk of ischemic complication. Anyway, the development of the endoscopic approach was also aided by technological advancement. For instance, robotic assistance enhanced the accuracy of the procedure, allowing to access the ventricular system, which is usually tight in these cases, via plant trajectory and providing stable support to the endoscope during the operation. Additionally, the use of laser has reduced the risk of thermal damage to the brain and allow for a more precise and regular cuts compared to standard monopolar coagulation. And finally, some authors have proposed innovative solutions, such as a device that allows for simultaneous tissue resection and aspiration under direct endoscopic visualization. Or another study proposed to combine endoscopy for direct visualization with radiofrequency ablation, as we already see. So, for the description of the hamartoma, and this method was indicated as particularly advantageous for medium and small size hamartomas, as it minimized the risk of missing the target during radiosurgery ablation when using a purely stereotactic approach. So, concerning our experience at the Bambino Gesù Children's Hospital, we treated 29 patients from 2010 to 2023. All patients underwent a standard pre-surgical evaluation, and according to the Delalande classification, type 2 hamartomas was the most frequent type. We have the pre-surgical evaluation, so with a normal and neurological examination in all the patients. In 37%, we have a delay of language or attention or hyperactivity. The psychomotor development was delayed in 6% of patients, 60% as aggressivity behavior, and the clinological assessment was reported precocious puberty in 2 cases and hypothyroidism in 1 case. So in our institution, we use the robotic system ROSA. Maybe most of you already know. This system is composed of a platform, including a touch screen and a compact robotic arm, mounted on a mobile trolley, which is fixed to the 3-pin support applied to the patient head. The robot arm can support and guide several surgical instruments through 6 degrees of freedom, 3 possible interaction modes, axial, isosensitive, and free, and 3 speeds. During the pre-surgical phase, the trajectory is planned offline on a dedicated software, and the ideal trajectory corresponds to a straight line between the center of the hamartoma, insertion at the floor of the third ventricle, and the contralateral foramen motor, so defining the focal and the frontal entry point. Intraoperatively, the planning is copied into the same software on the robotic device. The registration is performed according to a frameless manual and the automatic laser scanning of the patient's face. A bar hole is made according to the planned entry point. A rigid 30-degree endoscope held on the robotic arm is moved from the cortex to the ventricle under navigation control. Once the ventricle is reached in axial mode, the endoscope is moved to the target point within the third ventricle by switching to the cooperative or free mode. The insertion line of the hamartoma is identified. Okay, and this connection is performed using a thulium laser or monopolar device. In order to achieve the maximal disconnection, we perform multiple coagulations within the lesion, and also multiple tissue samples are sent for histopathological examination. So an overall number of 38 procedures was performed. The procedure was repeated twice in 6 patients, 3 times in 1 patient. After surgery, we had 3 transit deficit, 1 hemiparesis and 2 hormonal imbalance, and 3 fevers, okay, and 1 permanent hypothyroidism we saw in our series. With a mean follow-up of more than 8 years, 68% of patients were seizure-free, and most of them had a type 2 hamartoma. And in more than 50% of cases, reduced the therapy, and 27 stopped the anti-epileptic drugs, and the rest was unchanged. So from a neuropsychological and other profile, we have a worsening profile in 5 patients from a neuropsychological point of view, and also in behavior, and also from an endocrinological perspective. So if we consider the seizure outcome reported by the literature, you can see that seizure freedom range from 37 to 77% of cases reported. But I think it is interesting to distinguish the disconnections, the real pool disconnection series from the resection approach. And results are, I have not done a statistical evaluation. Anyway, they are quite similar in both of this approach. In this meta-analysis already mentioned, epilepsy and related with treated by endoscopic resection as a statistical significant result in terms of seizure outcome in respect to radiofrequency, and a lower neurological profile in respect to open microsurgery. And these are other review made by Concetta Luisi, the epilepsy surgery, the seizure freedom, which are more or less than 50% of cases, and the most of cases were type 2 hamartomas. So the most frequent complications reported include short-term memory disturbances, hemiparesis, hormonal imbalance, third nerve deficit, and diabetes insipidus. But if we consider the same literature I considered before, you see that in this connection approach was related with zero long-term complication, while for the resection approach, the complications are higher, with also death, brain infarct, and other serious also problem related to hemorrhage, ischemia. So, and finally, I would like to mention the most large pediatric series treated by the French group, and including 112 children with a mean follow-up of 4 years. The Angle 1 class was reaching 57% of patients, and anyway, the reduction of seizure was at a good level. Most of them was type 2, and complication rate was 80%. So going to the conclusion of my presentation, considering the results I have shared and also the previous discussion, the question in my opinion is, do we still see a reasonable role for endoscopy in the treatment of hypothalamic hamartomas? Or should it be considered an outdated approach? I don't have any definitive conclusion. Anyway, endoscopy offers the advantage of direct and multidirectional visualization of the hamartoma, enable a real-time monitoring on disconnection, intralesional ablation, and histopathological sampling. It is a minimally invasive approach that reduces operative time, postoperative discomfort, and hospitalization duration. It is a repeatable procedure, and the combination with a robotic system enhances stability, safety, and comfort for the neurosurgeon, and it is a relatively low-cost option. On the other side, it may be associated with complications due to the challenges of working with a narrow space within the ventricle and the risk of postoperative CSF leakage, when especially in bilateral insertion of the hamartoma, the visualization could be insufficient, and a sufficient experience with neuroendoscopic procedure is required. So maybe possible cases where endoscopy may be particularly advantageous include type 2 hypothalamic hamartomas, or situation with a higher risk of missing the target during the laser probe placement, especially with small or residual lesion. And I can give you an example concerning this 20-year-old boy who was operated twice to an open surgery for a big hamartoma. And for the seizure recurrence, we evaluate the situation at MR with the two components of the residual hamartoma, one more cranial and more deeper and close to the prepontine and interpeduncular system. So we decide to consider this cranial the component of the residual hamartoma for a disconnection approach, endoscopic, and the patient after 20-month follow-up is still seizure-free, and maybe to consider a laser for the more deeper component by a laser approach in case of seizure recurrence. But this is also a matter of discussion today. So sorry for my English. Thank you for your attention, and that's it.
So thank you, Alessandro, for sharing us one of the largest series of endoscopic disconnection for hypothalamic hamartoma. And now, if you have any question about it.
Thank you very much. Congratulations for your speech. I have a question about the seizure recurrence, because you showed there is no 100% seizure freedom. So when patient has a recurrence or they are not seizure free, how do you know that it's not a good disconnection, or they have a secondary focus or foci? I mean, how do you handle that? It's not easy, but...
So you mentioned the seizure-free?
Yeah, because when patients, they don't become seizure-free,
Mm-hmm.
and they still having some seizures, or they have seizure recurrence. How do you know that this patient can have a reoperation, or they have a secondary focus, extra deletion, out of deletion?
Okay, so I think that this aspect will be mentioned by Dr. De Palma in the next presentation. Okay, thank you.
Thank you very much for your talk. Really enjoyed it. I have a technical question. I understood that your trajectory is pre-planned with the robot, but how do you assess how deep you are going with your probe? Because once you're inside, you don't see it anymore. Do you measure it beforehand, before you're starting?
We calculate the insertion. We measure the insertion line, and then we adapt the tip of the laser according to this number. So and then in this way we know how long will be, how deep will be the disconnection.
Okay, and do you have then to readjust a bit or multiple times? Because I can imagine in a spherical lesion, if you are posteriorly, then it's maybe deeper than anteriorly. Do you have to adjust this?
Yeah, we adjust. We calculate for each point of along the insertion line the deepness, and so but we adapt the laser according to the highest deep.
Mm-hmm. Thanks.
Thank you very much for talking. I have one question about the size or diameter of endoscope you're using that should be pushed through narrow foramen, Monroe. What is the size, the diameter of this endoscope? Is it 5 millimeters, or you have smaller?
The size of the endoscope?
Yes.
Yeah.
Do you know this? Because foramen Monroe in small children
5 millimeters, yeah, 7 millimeters. The diameter of the endoscope.
Yeah.
Is not fully round, but it should be 5 millimeters, yes.
5 millimeters. And you are always successful to go through foramen Monroe when you do this?
Yeah,
without harming fornix or something like that?
No, for this reason, it is important to plan the right trajectory to avoid and to prevent the damage of the fornix. And usually, if you wash with more water, you can maybe reach to improve the size of the ventricle, and this can help you in moving inside the third ventricle.
Thank you. Have you ever tried to do this freehand without robot assistance?
No.
Thank you. Let's go now to our next speaker, Dr. Luca De Palma. He works here in Rome in Hospital Bambino Gesù. He's a pediatric neurologist, and of course he's going to cover more the neurological aspects of this complex syndrome of seizures and behavioral disorder of hypothalamic hamartoma. He's going to speak about the development of standardized management guidelines, epilepsy surgery, and beyond.
Thank you very much for the presentation. So, what's my duty as the last speaker is just to navigate a little bit in the papers that tell something about the outcome and see which are of the previous contender who is the winner. So when we spoke about hamartoma, in reality, it's quite, from a clinical perspective, the pediatric neurologist perspective, is quite a complex disease in which we have several domains, like in all other DE, developmental and epileptic encephalopathy. So we have seizure, we have cognitive function, we have behavior, that especially in this case could be quite troublesome, and then we could have some problem related to endocrinology. So for the sake of time, my analysis will be related only to the neurological cognitive seizure outcome, and I will skip endocrinology. So let's start from seizure. The first question is, as you have seen from the previous speaker, there was only spoken about hypothalamic hamartoma, okay. But hypothalamic hamartoma is something homogeneous, so we are speaking like FCD2B, the bottom of sulcus, or it's something more complex. So every patient is the same, or we should rethink our treatment based on which patient we have. So what we know is that from 1995 in Grenoble, that the hamartoma is the responsible of the seizure. So mainly if you put electrodes in the hamartoma and in other region, the seizure tends to start in the hamartoma and then diffuse in the other part of the brain. And this was quite confirmed by other study that the hamartoma displays some wide range of interictal abnormalities that could be similar to the one of FCD type 2, so polyspikes, spikes and wave, altered background of activity, and HFO. So that implies an intrinsic epileptogenicity of the hamartoma, so that the fault is of the hamartoma. But if we look at the few studies that have a Kaplan-Meier, so that can study the long-term outcome, this Kaplan-Meier seems quite different from the one of FCD type 2. The main difference stands here. So you have a lot of patients that clearly this is not this is for surgical procedure, not radiosurgical procedure, because in the radiosurgical procedure the curve will be different. But for surgical procedure, you have a lot of patients that falls, so recurred seizure at the beginning of the post-surgical outcome. With the limitation of the number that I've put here, so this is a resume of several techniques made in Phoenix. What we can say, but okay, we know that when we have late seizure recurrence, it means that something new happens. You didn't know at the moment of surgery, but something new happens. When there is an early recurrence, usually either is the fault of the clinician, so there was, I told to the surgeon there was a lesion and the lesion were 2 or multiple or not surgical, or it's the fault of the surgeon, so he wasn't able to ablate completely the lesion that was pointed out. So let's start from the surgeon. So if we have problem, the surgical technique has problem to map all the lesion, the supposed epileptogenic lesion. So this is quite clear. So what we know is that not every surgery has the same seizure freedom rate, and that hypothalamic hamartoma has a lot of problems because it's in depth, it's a region very near to a highly functional region that is hypothalamus, and that the surgical outcome has really increased in the last year, and this was confirmed by the meta-analysis of the chairman, so in which you clearly have that radiofrequency thermocoagulation and lead has a better outcome than endoscopy and of radiosurgery. But you have always to take in account that radiosurgery has a better safety profile than the other techniques. So I don't know if we have really to maximize only seizure freedom as a first-line treatment. But what we really didn't have so many information, it's whether the treatment should be personalized for the type of hamartoma. Here, to analyze the literature is quite complicated. We tried to do, but for example, in the Marseille paper, there is another classification of the hamartoma, so it's difficult to compare the study. But for sure, the type 4 hamartoma seems to be the most difficult, and probably the not for every surgical technique. We have heard that radiosurgery probably with very large hamartoma could not be the best, and also I would say that our endoscopic disconnection could not be the safest. And then there is something that we don't know. If there is a part of the hamartoma that should be privileged in the disconnection. So there was this hypothesis made in 2011 that the posterior aspect of the hypothalamus was the most important one, but then very few confirmation studies comes from this. So we don't know. I think that there was a question from the first speaker whether we can have a really tight disconnection of the most epileptogenic part of the hamartoma, or we have to resect all. Clearly the answer was up to now we don't know, and the indication is to have a wall damage of the hamartoma, but probably this should be really investigated. And then, so not clear answer from this point. So there are a lot of doubts in the literature. And then if the problem is come from the clinician. Here it's more clear, the problem. So yes, the problems could come from the clinician. We know that in several patients, seizure can come outside the hamartoma. Here we have a seizure that was in the hamartoma. Here a seizure that was contemporary in the hamartoma in the left temporal lobe, and here a completely independent seizure that was in the right temporal lobe. So I mean multifocal seizure. Why this has happened? Oh, this is quite clear from the literature, so that not every patient is the same. So that there is one group of patients who has multiple type of seizure, cognitive impairment, more behavioral disorder, so more DE features, and a group of patients who is with better cognitive performance and no behavioral disorder. And what is the difference between the two groups? The only things that we know is that duration of epilepsy, so the age. So it seems that the more you wait, the more you can face to a patient who is more complex. And these are the data that comes, again, mainly Strasbourg and Marseille. So the more you wait, so you pass, the blue are the good one. So you see that the more you wait for the outcome, the more you risk of having complex patients that probably are no more suitable for simple hamartoma disconnection, resection, radiosurgery. So from trying to have a summary of what I told you, it was quite not good, because except from the age of surgery, and it's related to the duration of the epilepsy, the other predictors were really scattered. I put a photo from our paper because really the number changed every time. So it means that one predictor was in one paper, and then no one was able to replicate that predictor. So the strength is really low. So at my first conclusion regarding seizure, I could say that there is a limited evidence that a short duration of epilepsy and a better cognitive status that probably is related to the short duration epilepsy before surgery may predict a better seizure outcome, that radiofrequency thermocoagulation and LIT have a higher seizure freedom rate, but long-term outcome studies are very rare. So it's difficult, except from the Marseille paper and some with the American study, but they have really problem of losing a lot of patients. Really long-term outcome studies are rare. So if we move to cognitive performance, clearly, this is a confirmation of what I told you before. The more you wait, the more patients with hypothalamic hamartoma gain problems, gain cognitive problems. And this is clearly related to age. And clearly, if you insist with drugs, to the dose of the anti-seizure medication, sorry. And while for the post-surgical performance, I don't know, these are studies done with more invasive technique, but it seems that the more invasive you are, the risk for the patient who are very well functioning is high. So to privilege less invasive technique, because with a lot of invasive technique, there could be more seizure freedom, but you lose cognitive outcome. And clearly, the aged surgery and duration of epilepsy correlate with cognitive improvement, and most important, the only patient that really could improve after surgery are the one with seizure-free, in which you can taper the drugs. So you have to balance this. And last, the behavior. The behavior, I will go very fast because it's really the same story as cognitive outcome. So the more you wait, the more problem you have. And really the curve is really similar. If most of the patients who can reach a seizure freedom rate could have a good improvement both in cognitive and in psychiatric outcome. But if you do not have a seizure freedom state, remember that the patient with the hypothalamic hamartoma have a wide range of behavioral and psychiatric problem, affective disorder mainly, most, and anxiety disorder that cover almost 80% of the cohort, so pay attention. So my second conclusion is that there is, again, limited evidence that the cognitive and neuropsychiatric profile may improve in most patients after surgery. And if you are quite aggressive, you can lose some cognitive function. So this is, I don't know whether it could be related to the fact that probably your first surgery, if it's feasible, and you don't really know, just as I told you before, we don't know which hamartoma could be really better for really non-invasive technique, but probably if you do not want to lose cognitive, you can be less invasive at the beginning. So I would thank Dr. Luisi, who was able to finish our meta-analysis, and Dr. Benedictis, who did all the surgery, and all our team. Thank you very much.
Yes.
Okay. Yeah. I should ask you a question of before.
Yeah, hi, Luca. So thank you, Walter. Thank you for your presentation, very nice. I'm still wondering about, because you implanted the patient, you before the, whatever you did, thermocoagulation therapy, etc., whatever, you implanted the patient looking for extra hamartoma focus, isn't it? I mean,
so this study comes from Marseille.
No,
it was under
okay.
this part of publication comes under a more complex project that was the virtual epileptic brain, and it was just to understand why we fail. So for sure, their demonstration is that in some patients, hamartoma, it's not the only problem. So that the seizure may come outside the hamartoma.
Exactly. So that's my question. Where or how, when do you have to start
it's only
thinking?
Yeah, the only evidence that you have is time. So if you do it fast, you have the less risk of being in that situation. So of multiple seizure type and so probably an extra hypothalamic epilepsy. But if there are inner features of your patient that could tell you that, I mean, at an age where you usually cannot do, or it's complicated to have stereo G, because my suggestion is to go very fast, so not waiting the time you can do stereo G or whatever. So I don't know. There is nothing written on that. Because as you see, most of the paper did not report really the clinical profile of the patient. So we don't have much information in this cohort of which type of patients are. So my suggestion is only go fast, operate early, and if you have a very I mean, an old patient for hypothalamic hamartoma, so I mean, from 20, it's already a very old patient. Probably the risk of having multiple type of seizure and having a less seizure freedom state, it's really high.
Hi, and thank you for your presentation. My question is also for the audience. I was wondering whether in your experience post-surgical patients who experienced a worsening in their cognitive outcome and behavioral outcome were also the one who didn't gain a seizure freedom. Like, have you ever had a patient who gained complete seizure freedom, but still declined in cognitive outcome and behavioral outcome? And if yes, which are the hypotheses, in your opinion?
So this is already reported. I didn't address it specifically in my presentation, so that there could be a disalienation between seizure outcome and behavioral and cognitive outcome. So especially there could be patients with a lot of behavioral problem that and cognitive problem, the intellectual disability that could reach seizure freedom state. Usually it's not related to a post-surgical problem. Usually these patients have the deficits from, it's inside the problem of hamartoma, so it's not only post-surgical. We really do not know. I do not have I think we didn't find anything written on that. We don't know why. This is the main reason why the recommendation up to now is not doing stereo G, because the stereo G was just an example, but the recommendation up to now is not doing stereo G, but just to do something on the hamartoma, because the other things are simply impossible to do, or we don't know which benefit could give.
I guess the mechanism may be related to the worsening that we see in other patients with sudden cessation of seizures after epilepsy surgery. This classic concept of forced normalization that we sometimes see, rarely, but sometimes after epilepsy surgery. So we really don't know what's happening, and we don't have a good explanation for that.
I have a question to all speakers. In case you have a failure after a first procedure, and say you're doing a second procedure, when is then the point where you're saying, that's enough, I cannot do anything more? What is your, let's say, limitations in your everyday practice to say, well, we can't do any more for this patient, or we're trying to do another approach? Any comments on this from the speakers?
Which type of hamartoma and which type of patient? So
all of them. Let's say in the experience of the speakers, what is the limit to offer any invasive procedure? Are there any type of hamartomas where you say, well, I'm not gonna do anything else in this one? Or are there any other types or clinical scenarios where you would say, this patient should be, from all that we know so far, this patient should achieve seizure freedom, I'm gonna push the limit again? Any comments to that?
There is not any limit. The limit we use is as far as we see remnants of the hypothalamic hamartomas that we suspect that are not ablated, we can perform another surgery and another one. And if we see that everything is ablated, then we perform a tractography. If there is no tractography, no tissue that we think that could have viability, then we stop. But if there is any possibility, if there is tissue or the tractography shows any tract, then we ablate again.
Yes, that's the same also for us. So it depends, as the case I showed before, it depends also the morphological aspect of the residual. So if it is easily reachable by the endoscopy, and maybe we talk with the family on the possibility that. But it depends also on the family request, because it's the gravity of the epilepsy, the entity of the seizure recurrence. So in this case, for example, the patient has many seizures. So the parents told us we try. No, but yes, I try if there is a safe perspective.
So all patients that you have treated and are seizure-free have a complete disconnection or resection, I can assume then? And are there any patients that are incomplete and are still seizure-free?
No. But from the literature, no. I mean, it's the paper that I show with of Phoenix group was really indicating that there is a trend of how aggressive you are on the posterior part or on the anterior part, but it's only a trend, clearly. I mean, because as the wall of the the limits between hypothalamus and the hamartoma is very thin. I mean, it's just it's just a matter of how you consider the residual tissue. But I mean, a complete removal, it's not still, there are no published that we have a review that still have correlated clearly with the outcome.
Yeah, and I think this is maybe the reason why the idea that not the hamartoma tissue is homogeneous concerning the involvement of seizures. So I think it is reasonable. So some areas are more directly involved in seizures degeneration. So if you reach the disconnection, this specific area, the result will be better.
So it's 4 o'clock. We can try to give a kind of summary of what we heard about the different technique, and we can say that we heard a presentation from very expert of each technique. So this has to take into account when we think about which kind of surgery we can propose to this patient. And to summarize, we can say that radiosurgery seems that is a bit less effective than other techniques, but has still a role since following the Latin motto, first not harm, radiosurgery looks like to be the safest. So it's something that has to take into account when we deal with a single patient. Then the endoscopic disconnection overcome the issue of the microsurgery, getting very good results, because the results of the endoscopic from the largest series, such as that of Rome, it's very similar to the outcome of other techniques like laser and radiofrequency thermocoagulation, but is very limited to the type 2 hamartoma or some other, not to all type of hamartoma like the largest one. The LIT is the newborn, and I think that in the next years we will have also strongest data about the longer follow-up. So I think that we would like to see your data updated with a publication in the next months, because I think it's very useful to have your data with such a larger series for everybody. And we have to take into account that LIT is very expensive. So for many centers, we have the big issue of acquired fibers. And for this reason, radiofrequency thermocoagulation, which is a very old one and also probably less safe than the LIT, because you cannot have the thermometry intraoperative, can be a solution. Can be a solution in countries or in centers on which you cannot afford the cost of the fiber. So we'll see in the future if it will have space, such as the focus ultrasound. The problem of the focus ultrasound is that you cannot burn, I would say, old lesion in the most cases. So you should follow the concept of disconnect the hamartoma, even though we know that the disconnection of hamartoma sometimes is more theoretical in some cases, to leave in place a huge hamartoma to try just to disconnect the attachment to hypothalamus. So we don't know if with this machine of focus ultrasound we could have very useful results. And another point, very relevant point, is that not all the centers have the possibility to have all the technique. I think that there is no center in which you can do radiofrequency, laser, radiosurgery, endoscopy. So it also depends of the facilities of each center to try to maximize the effectiveness of each technique. And sometimes when you are not able to treat a patient because, for example, you have a huge hamartoma that you already disconnected and you cannot make, for example, the laser ablation, it's worth to send the patient to another center on which you have this kind of possibility. And it's easier in countries like in Italy, in which there is a good collaboration between the epilepsy surgery center, and this, I think, is very relevant in such a complex surgical management like that one of hypothalamic hamartoma. So thank you very much for the speakers and the audience. It was a great pleasure to have you here. Thank you, Mar.
Thank you.